My chosen disease was infective endocarditis. Also known as a slow death, the first earliest documented valvular inflammation was in 1554. And then there was a description of aortic valve vegetations by Lazare Riviere in 1646. The time period of 1824 and 1835, Jean Baptiste named the endocardium and endocarditis, linking it to acute joint rheumatism. And then in 1878, Klebs and Rosenbach proposed that IE was caused by bacterial origins. In 1885, Sir William Osler synthesized 200 cases and classic stigmata of malignant endocarditis in his Gladstonian lectures. He also disproved the theory that it was linked to acute joint rheumatism and basically classified endocarditis as its own infection. In 1910, Emmanuel Liebman described acute and subacute endocarditis. 1994, Duke published Duke Criteria, integrating endocardiographic findings as major criteria, which I'll talk about later. So what is IE? IE is an infection of the endocardium. It is divided into acute and subacute classifications. Acute having a sudden onset and high mortality rate, subacute developing slowly with a lower mortality rate. We can see right here in this picture, the endocardium is this kind of yellowish colored layer right behind the myocardium. Some causative agents, number one being Staphylococcus aureus. It is a gram-positive bacteria. It is the major agent in acute IE. It is highly destructive and has a high mortality rate. It produces coagulase, allowing it to build a network of fibrin around itself, shielding it from the immune cells, so it creates that biofilm, which causes that high mortality rate. Streptococcus viridans is also a gram-positive bacteria. It is seen more in these subacute infections. It produces dextrins that allow it to anchor tightly to pre-damaged heart valves, and we see this bacteria mainly seen with people after dental work. Another one is Enterococcus faecalis. It is also gram-positive. We see this in subacute and acute cases, and this one is seen more in healthcare-associated infections. It has extreme resilience and thrives in harsh environments, possesses high intrinsic resistance to common antibiotics. This would lead to higher mortality rates in that acute infection classifications. How is IE transmitted or developed? Well, it is not a contagious disease. It does not spread from person to person. You can get it through dental work, IV drug use, contaminated catheters, surgeries, skin infections, body piercings, tattoos, and so on. Once it does enter the bloodstream, the bacteria moves its way to the heart and attaches to damaged heart tissue, and it can also attach to prosthetic valves. So besides affecting the cardiovascular system, it can also affect the brain, kidneys, lungs, spleen, and so on. It does this by traveling throughout the bloodstream, and as well as causing embolies, which can move around to the body, causing the blood clots and lack of blood flow. And that's what can also cause the strokes that we see here that affects the brain. Epidemiology, we see about 15 cases per 100,000 people annually. In developing nations, historically we thought it was due to untreated rheumatic heart disease. We still see that today in the developing nations, and it affects younger populations as well as children and young adults. Here in the United States, as well in other developed nations, we now see it more in healthcare-associated infections, people with pacemakers, catheters, prosthetic valves, as well as IV drug use. It mainly affects the elderly, people 70 and above here in the United States, due to the degenerative valve disease, as well as the prosthetic valves or catheters or pacemakers that we see in those older individuals. However, due to the intravenous drug use, especially with the drug pandemics we see across the United States, people using the unsterile needles, we see that causing IE in the younger demographics here in the United States. Some signs and symptoms. Common symptoms are fever, chills, night sweats, weight loss, heart murmurs, chest pain. As well, you can see here some signs are splinter hemorrhages, which we can see in the fingernails right here, these kind of darkened areas on the nail, as well as raw spots, which are in your eyes. You can kind of see right here, kind of off to the side right here, this kind of orange cluster with a really white spot in the middle. That would be a white raw spots. Genway lesions and ossular nodes and the petechiae. These are kind of like painful red bumps on our fingers, soles, palms, on our legs, on your toes. That's what those would be. Ossular nodes is named after Sir Osler William, or Williams Osler, who I mentioned before. So how does this disease progress? Well, first, damage to the heart valve occurs, and then platelets and fibrin accumulate on that heart valve. Once the bacteria enters the bloodstream and makes its way to the heart valve, it attaches to that damaged heart valve, creating a biofilm or vegetations, and destroy that valve tissue. And then pieces of that vegetation in heart valve may break off and enter the bloodstream and move into different areas of the body, causing blood clots, strokes, and as well as preventing blood either entering the heart and getting oxygenated or preventing blood flow throughout the rest of the body. In this picture right here, you can kind of see the vegetation building on the heart valve right there, which would also turn into a biofilm of that bacteria. So diagnosis and laboratory testing, this is where the Duke criteria comes into play. Duke criteria requires 2 major findings or 1 major and 3 minor findings. Some major criteria are blood cultures, echocardiography, which is just ultrasounds of the heart, which shows the vegetation or abscesses of the valves. Minor criteria are predisposed heart conditions or IV drug use, a fever greater than 38 degrees Celsius, vascular phenomenons, and immunologic phenomenons. There's also supplemental lab tests we could do, like electrocardiograms or EKGs. This shows whether that the infection has eaten to the electrical system of the heart. We can also do PCR testing to detect bacterial DNA if cultures come back negative from the blood culture. Patient prognosis is a high mortality rate with 15 to 20% of cases ending in death. Full recovery is possible with early detection and by completing the 6-week IV antibiotic regimen. However, scarring will pretty much be permanent. Severe complications include congestive heart failure as well as neurological deficits like stroke and infections in the brain. Treatments are IV antibiotics like vancomycin and gentamicin. Surgery may be required, however, it is not the preferred method due to other infections occurring or more acute IE infections occurring. Prevention can be avoid sharing needles or good oral hygiene, regular dental care, timely treatment of bloodstream infections, proper wound care, also prophylaxis for high-risk patients, that being people with pre-existing heart conditions when they go in for dental work. Research right now includes biofilm penetration, so figuring out how we can basically break down the biofilm that is created on the heart valve and resensitizing these bacteria to antibiotics. Also, bacteriophage therapy. There's high rates of MRSA endocarditis now, which is the Staphylococcus aureus, which is the most fatal. We're looking into ways to use phages to be able to clear up the MRSA vegetations, as well as molecular diagnostics, so that PCR diagnostic, looking for DNA bacteria that has quicker results, eliminating the multi-day time for traditional blood cultures. Although IE is not considered an outbreak disease, we are seeing an increase in IE due to healthcare associated infections and the intravenous drug use. It again affects approximately 10 to 15 people per 100,000 annually in the world. And this right here shows pictures of those prosthetic heart valves. So why did I choose infective endocarditis? My mom had infective endocarditis. The infection started in her PD catheter, which she had for Kidney damage, she was on PD dialysis, so there's a catheter that sits behind in her peritoneal cavity. It got infected, moved up to her heart. She did have a pre-existing heart condition called mitral valve disease, so it basically latched onto that. She did pass away in August of 2025. This is a picture right here of her. Please excuse her face. She was crying because this was at my college graduation back in 2023. Some key takeaways. IE is a localized infection with systemic consequences. It acquires both endothelial damage and invading bacterium. The hallmark of the disease is vegetation that continuously pushes embolises into the bloodstream, causing unique signs like Osternoz and Roth spots in the eyes. Despite advances in diagnostic criteria and surgical replacements, IE remains a highly lethal condition. Shifting demographics require scientists to focus on new research like phage therapies and biofilm disruptions.